the radiographical evaluation. CT scans are the gold standards for the radiographical evaluation of the zygomatic fractures. The coronal views are particularly helpful in the evaluation of the orbital floor. As here you can see, there is disruption of the orbital. There is disruption here, and the extraocular muscles are herniated into the maxillary sinus. This is the coronal view, and here there is depression of the zygomatic arch. The other views for radiographical evaluation are the Waters view. These are basically helpful for the visualization of the sinuses, lateral orbits, and intraorbital rims. Then submantovertex view, which is used for evaluation of the zygomatic arch and the malar prominence. Next, coming to the symptoms of the zygomatic arch: chymosis and edema. Then there is depression of the malar eminence. Subconjunctival hemorrhage is present. Downward displacement of the zygoma produces antimongoloid slant to the lateral canthus, enophthalmos, ecchymosis region in the canine fossa, and there is decreased mandibular motion. Then there is limitation of motion of the ocular muscles in all 9 planes. Diplopia and enophthalmos is present. Lack of pupillary response and ptosis, and injuries to the optic nerve, hyphema, and injury to the globe is also seen. Epistaxis is seen in 50% of the ZMC fracture due to disruption of Schneiderian membrane of the maxillary sinus, and bleeding exists from the ostium of the nose. Then treatment. For treatment, at least there should be a wait for 7 to 14 days so that the edema may subside, and one may be able to come to the conclusion of deciding whether the zygomatic fractures has to be operated or not. The main reason for not operating the displacement is the lack of displacement, and then there is risk of blindness in the uninvolved eye. The next decision is if the displaced zygoma can be treated in closed reduction, and the criteria for the closed reduction is that the fracture, there should be no comminution of the fracture, then floor and medial wall should not need exploration, then fracture of the FZ suture should not be wide. So once these 3 things are met, then the closed reduction can be done. Reduction can be done when open reduction is sought. The reduction can be done in 3 methods: the Gillies method, which is also called as temporal method, then Keen's approach, which is the intraoral approach, and Carroll-Girard approach, which is a T-shaped screw. Coming to the Gillies approach, the medial portion of the temporal fossa is shaped. The bifurcation of the superficial temporal artery is identified and 2.5 cm superior and anterior to the helix of the ear. incision is made in the anterosuperior and posterior inferior direction, and temporalis fascia is exposed. Then periosteal elevator is inserted between the fascia and temporalis muscle, and the blade of the Rowe's Rowe's zygoma elevator is inserted in the created space. The instrument is pulled superiorly and in lateral direction for the reduction, and other hand is put on the fracture side for the evaluation of the reduction. Then next approach is Keyes approach. It was introduced in 20th century by Keen, and 1.5 centimeter incision is placed in the buccal sulcus in posterior direction, adjacent to the attached mucosa in that region. Then periosteal elevator is inserted, and to introduce the incision, exposing the infratemporal surface of the maxilla and zygoma. Next, the medial surface of the zygomatic arch is dissected free, and the flat blade of the Rowe's elevator is inserted or introduced in the incision and placed under the infratemporal surface of the zygomatic bone. With surgeon's free hand over the operative site, elevator is pulled superiorly and laterally.